Greetings. As everyone knows, we're in the middle of a tremendous pandemic regarding the coronavirus, which has affected people from around the world. Last week, I was able to network with the Chinese in a webinar, exchanging ideas and thoughts regarding the relationship of venous thromboembolism and the coronavirus, and certain other experiences, and I'd like to share those with you today. There is no question that the disease burden of COVID-19 is serious around the world. The Chinese have been developing guidelines for VTE prevention and treatment, including individual thrombosis risk assessment, thrombosis prophylaxis and treatment guidelines, and supportive care including blood sugar control, stress-induced GI bleeding, and so forth. This is a nationwide program initiative that's been going on for at least 5 years. It's a big program involving many hospitals, many centers throughout the country, and it has been very helpful in trying to organize efforts to decrease the incidence of venous thromboembolism. We know that venous thromboembolism is the #1 preventable cause of death after surgery. And we also know that most of the COVID-19 hospitalized patients are at high risk of venous thromboembolism. In order to further define and explain these special characteristics in these patients, I'd like to refer to Virchow's triad. And Virchow was a famous pathologist who put these postulates together in 1856. And he said the risk factors for developing a thrombosis are endothelial injury, venous stasis, and hypercoagulability. And if one is present, there's a slight chance of venous thrombosis. If two are present, it increases the chance of venous thrombosis. And the chance of venous thrombosis is the greatest when all three are present. So let's take a look at slow blood flow, venous stasis. When a person is at bed rest, especially if they have a low blood pressure, even if they're in shock, or of course in coma, or if they've been sedated, or on mechanical ventilation, they're not moving their legs. The blood is puddling in their legs. But at the same time, the muscles are still producing metabolites and waste products. They're secreting into those venous segments. And they're supposed to be propelled out of the leg with the contraction of the muscles, but that's not occurring. So not only do you have that venous stasis going on, but you have a hypercoagulability because those waste products can trigger clotting. In addition to that, the patients, due to their condition, their fever, dehydration, inflammation, infection, hormones, immunoglobulins, that can all increase coagulability. And then the patient's baggage, that unique collection of risk factors. Suppose the patient had a past history of a thrombosis. Then they're even more likely to develop a clot. So there's tremendous hypercoagulability forces going on now in this static segment. And as a result of that blood puddling in the veins, the arterial blood is continuing to pump into the leg, so that after a while the veins will get over-distended or overstretched like a balloon beyond its capacity, and the lining of the vein wall will crack, and that will expose the subendothelial collagen to the blood, and that triggers clotting. It's a very powerful trigger. So you can understand when all of these factors that are present in these patients, especially the sick patients, that the chance for blood clots is very high. So what about preventative strategies? Well, one of the things that we have learned, and they shared with me what they have done as well, was low-risk patients, according to the Caprini Improver Padua score, are not given anticoagulants initially. And these would typically be patients who have had dehydration, Their anorexia or diarrhea without any medical comorbidities. And remember that just giving anticoagulation to everybody because they're into the hospital is not appropriate. We know from the work of Panucci in surgical patients, and we know from the large database from the University of Michigan in medical patients, that low-risk patients for developing venous thrombosis are not benefited by anticoagulants, and that does not further lower a low DVT rate. But what's more important is those anticoagulants can cause bleeding complications or other allergic reactions and so forth. So those patients with low scores should be spared anticoagulation. High-risk patients, on the other hand, according to one of the scores, should receive prophylactic low molecular weight heparin or unfractionated heparin, especially unfractionated heparin if you're worried a little bit about an increased risk of bleeding because unfractionated heparin has a very short half-life. Now, all scoring should be done dynamically as the hospitalization goes along. So let's say this patient comes in with anorexia to begin with, but then progresses and requires a ventilator, gets very sick. Well, then you have to add those factors, and that takes the patient from a low score to a high score. And by the time discharge occurs for patients that survive, they should be rescored to see if they're still high score. They should probably get 6 weeks of anticoagulation afterwards. Now, you might say that these doctors and nurses that are running from patient to patient, furiously trying to take care of patients and to put out what you would say fires for emergency situations, that they don't have time to do all this scoring. Well, that's why you have a choice here of using the more simplified scores like Padua, or the more complex score like Improve, or even the most complex score like the Caprini score. These scores are all available on the phones as well, and certainly the simple scores can be done very, very quickly. Now, those patients that develop respiratory disease are automatically candidates for low molecular weight heparin if they don't have a bleeding contraindication. We know from the large medical trial, Metanox, comparing low molecular weight heparin to placebo, that was done in many countries around the world a few years ago, that those people with respiratory disease experienced a 75% reduction in venous thromboembolism using low molecular weight heparin. Now, we know that if there are patients at high risk of bleeding, we should use IPC. But remember, when you say that a patient's at high risk of bleeding, if that risk starts to lower, then don't forget about the anticoagulants. You can reintroduce them. Or in some cases, you can use unfractionated heparin, which has that short half-life, and that will help you to adjust if the patient has any bleeding. We know, of course, that patients with severe renal impairment are best served by being prescribed unfractionated heparin, and that's when their creatinine clearance is below 30 cc's per minute. The development of heparin-induced thrombocytopenia due to heparin use, which of course is much more common, over 2% with unfractionated heparin, whereas it's 0.2% with low molecular weight heparin. Nevertheless, if HIT develops, fondaparinux, argatroban, bilirubin, or rivaroxaban can be used, and commonly fondaparinux has been used and is relatively convenient for this situation. If the patients are taking food by mouth, of course, they could also have rivaroxaban. It is imperative that all patients with COVID-19 be monitored closely, looking for signs of venous thromboembolism. Now, it's recommended that patients have a D-dimer, fibrinogen, fibrin split product, PT and PTT assays on admission as part of their package. But if those patients that develop elevated D-dimers, fibrinogen, or fibrin split products, or prolonged PT or PTT, or thrombocytopenia, as well as clinical evidence of DIC, these are very, very high-risk patients. And under those circumstances, one has to make sure that they're being treated optimally with anticoagulation and pneumatic compression, as well as also screening them for a possible occult venous thromboembolism. The simplest and most practical way is using the POTUS protocol, P-O-T-U-S, point-of-care ultrasound screening, which means taking a handheld device, doing a two-point ultrasound over the groin and on the popliteal fossa at the bedside. It takes 5 minutes, and if a clot is picked up there, then that patient can be treated, hopefully helping to prevent a fatal pulmonary embolism. Now, depending on what's going on with the DIC, you know that when these elements get into the blood that trigger clotting, inflammatory cytokines from the infection, they trigger thrombin generation, it starts circulating, the patient becomes very hypercoagulable. And that's where you see the elevated D-dimer, and that's where the body responds by increasing fibrinolysis, and so the fibrin split products will go up. Often fibrinogen goes up under those circumstances. But also, there's another phase of DIC where you can develop a consumptive process. So the process of clotting is going on so fast that it's using up the clotting factors. And under those circumstances, normally the prothrombin time or partial thromboplastin time will be prolonged. D-dimer will still be up, but the fibrinogen may drop, as well as thrombocytopenia may develop. And under those circumstances, you might have to adjust the anticoagulant prophylaxis. You might have to introduce antifibrinolytics for markedly accelerated fibrinolysis. And also, it might have to be that you resort to something like extracorporeal membrane oxygenation under certain extreme cases. Finally, the preventative strategies that are employed by all of us and were reiterated in our conversations with the Chinese were accurate thrombosis risk assessment for all COVID-19 patients is absolutely imperative, using one of the risk assessment systems. Identification of high-risk patients that benefit from anticoagulant prophylaxis should be done, sparing those who are at low risk and giving the maximum prophylaxis to those that are high risk. You may even have to adjust the dose under certain circumstances. Don't forget about appropriate VTE screening for very high-risk patients who are suspected of having a clot or have elevated D-dimer or fibrin split product levels, using the POTUS, the point-of-care ultrasound screening technique with a hand-held Doppler at the bedside. And finally, something that we're all going to have to do as we move forward is conduct future research to determine the true incidence of DVT and PE in COVID-19 patients and how to best approach the problem. I'd like to thank the Chinese for our participation in this conference last week. I think we exchanged a lot of good ideas back and forth. And I would also like to thank you for listening to this. And please remember to go to www.venusdisease.com for more information. Thank you very much. And everybody, stay safe and have a great day.